thank you again for the opportunity to be here. And I can say that I always wanted to be a rock star. And so thanks to Marius and Gonzalo for making that wish come true. And after that happened, you can see that my hairstyle was a little bit different in that picture. I had to let it grow to, go incognito a little bit. So that's the reason. But anyway, let's talk a little bit about PCV3 today, noise or not. So when we think about PCV3, just as we know for PCV2, it's a virus that's endemic and it's present basically everywhere where pigs are produced. So these are here the countries that have reported detection of PCV3 in their pig population. So you can see that pretty much wherever pigs are important, PCV3 is there. When we think about PCV3 and what could be associated with it, these are all things that are in the literature that have been reported in association with PCV3. Now, the key word there is in association with, or the key sentence, because it doesn't mean necessarily that the PCV3 is causing those things. Those clinical signs were present, and PCV3 was found in association with those clinical signs. When we think about things for which we have a little bit more stronger evidence that the PCV3 is involved with, these are the things that we will be talking about. So PCV3 reproductive disease with abortions, mummifications, stillborns, and weak-born piglets, and postnatal disease with wasting, wilt drift, poor doers, rough hair coat, and kyphosis. But those are pretty generic clinical signs, so they could be attributed to a lot of other diseases as well. And that's why a detailed and thorough diagnostic process is needed when you're suspecting PCV3 involvement or you have the presence of those clinical signs. One of the things that have also been reported with PCV3 is these pigs that they have their ears caudally rotated. So you see those pigs that have, sometimes in the US they call this like Dumbo pigs, so they have their ears rotated caudally, and you can see that both in live pigs but also in stillborn pigs there on the top. So that's one thing that to be aware of. It doesn't mean that all pigs that have that type of ear presentation have PCV3, but again, it's one of those things that you should be aware of. Now, when we look at our cases at Iowa State, since we started tracking PCV3 diagnosis, this is about what we find in a year. And if we were to contrast that with PRRS, for example, PRRS is in the thousands per month. So PCV3, it's overall a very low number of diagnoses. It would be around less than 1% of the cases that we receive in the lab, we would have a diagnosis of PCV3 associated disease. And as you can see, it has also been pretty stable over the years. When we think about the ages of where pigs could be affected, there is a wide range of ages. So a lot here in the beginning where we have those weak-born, stillborns, or reproductive cases. And then you can have, for those postnatal disease, again, a wide distribution of age, but more concentrated here around 4 to 9 weeks of age. Very important for when we're thinking about PCV3 is when you submit tissues to the lab, we should always try to stack our evidence to be sure or to have like strong evidence that PCV3 might be involved in the clinical signs that we're seeing, right? So one of the things that we want to see is confirmed lesions that would be associated with PCV3 infection. One of those lesions, the main ones that we find is myocarditis. So if you're suspecting PCV3, make sure that you include heart, both fresh and fixed, to send to the lab. Other lesions, fetal mummification, abortion, a little bit of interstitial pneumonia, nephritis, stillborn and encephalitis. But again, those are also very restricted presentations. What it causes the most is inflammation around blood vessels. That would be the main thing, and that's what we see that multiple on the top that would be associated primarily with that multisystemic inflammation. So when we think about how do we diagnose this PCV3, right? So there are two different approaches that we can take. One would be to diagnose reproductive disease that would be associated with PCV3. So those same clinical signs that we talked about before, abortions, mummified piglets, stillborns, weak-born pigs. And then what we want to see is, again, evidence that those problems are present above the baseline that you would be expecting in your sow herd. And then on the histopathological analysis by the laboratory of your choice, you would expect to find this multisystemic lymphoplasmacytic to lymphohistiocytic perivascular inflammation. Very long word, just means that a lot of inflammation around blood vessels. That's what you'll be looking for, and that's what you should ask your pathologist if they are observing those lesions. And then the next step, very important, is the detection, right? But it's not only through PCR. We want to make sure that we're also finding the virus within those lesions that we're observing in the histopathological evaluation, because that would increase our confidence that PCV3 is really involved in those patterns of lesions. And I mentioned this before for the clinical signs, but it's also true that other pathogens can cause very, very similar lesions to this, the same as would be expected for PCV3. And that's why, again, it's important to be very detailed on your diagnostic process to make sure that you're excluding other agents that could be also causing those same lesions. For pigs post-weaning, if they have those clinical signs of wasting, weight loss, ill thrift, poor doer, sometimes neurological clinical signs, then the diagnostic criteria would be about the same. Weight loss, rough hair coat. Make sure that these have those same lesions that we talked about for those reproductive cases, so multisystemic inflammation around blood vessels, and then detection of PCV3 again in those damaged tissues. PCR detection, but also like in situ hybridization would be the most common technique for detection of those antigens within the lesions. Now, let's say you found it, right? And then you confirmed with a diagnosis within your herd. The first thing that I always say to the clients of the VDL is you want to make sure that PCV3 is really the cause of that. So let's say I find it in a diagnostic case. I always suggest to the client, hey, maybe you should go ahead and collect more pigs that have that same clinical sign and bring to the lab so we can confirm that PCV3 is truly involved in that clinical presentation. So it's a little bit about building that redundancy, again, just to make sure that you have strong evidence that PCV3 could be the case and it's not something that you missed in the first diagnosis. The thing with PCV3 is that there are no commercial vaccines available, right? So your options in that sense are limited. Basically, you gotta go for control of other things that would allow that the animals take care of PCV3 by itself, right? So what do you want to do? Control environmental stressors and triggers, and also control all of the possible infectious disease cofactors that could be playing a role in allowing PCV3 to manifest itself. So for all of those pathogens that you have vaccines that are proven and that will be effective in controlling disease such as PRRS, PCV2, parvovirus, and others, that's what you should be aiming for. So to finalize here with our take-home messages, PCV3 is very common to find, so it's important to differentiate detection versus causation. vertical and lateral transmissions are possible. Co-infections are very common and may impact, the impact is not clear on PCV3. The diagnosis require clinical signs, lesions, and in situ hybridization or immunohistochemistry. Commercial vaccines are not available, and it's important to control other pathogens and environmental stressors when you can to prevent PCV3 from manifesting itself. And that's it for now.
Thank you very much for a very comprehensive description of the situation with PCV3. And I said that it was the last presentation before coffee, but I was kidding. We have one more chance to hear from our experts. Let's see who the last presentation before our tea break will be. So, another chance for the rock star to join us on stage. Welcome back.
Thank you very much. Here we are again, guys, talking about PCV2 this time. So, for these pathogens that are endemic, PCV2, PRRS, a lot of the bacterial pathogens, we do have a lot of different diagnostic modalities that are available to us. But sometimes, you know, having too many tools can a lot of the times muddy the waters. And that's why, again, it's important to use those strategically so you can get the answers that you need, so you can apply the interventions that are going to help you deal with those, right? And that's very true for PCV2. So when we think about PCV2, it's very, very important to differentiate between just detecting or diagnosing it, right? So here are some of the tests that are available. And one of the things that I always say is that you have all of those, but don't use any of those if you don't have a very specific question. So before you decide which tests you're going to run, it's important for you to have a very clear understanding of what's the question that you're trying to answer and what you're going to do with the information that's generated by that test, right? If those two things are not clear, you know, don't test. Don't test. Stop right there because, again, that might just mud the waters for you. So we have PCR. We have three different types of PCR, or three different ways that you can apply PCR. You have just a regular PCR that would just be for screening, that would tell you like if the pathogen is present or not. And there are a number of sample types that can be used for that, so processing fluids, tongue fluids, oral fluids, or even tissue. You have your qPCR, your quantitative PCR, that's going to allow you to tell how much virus it's in that sample type, right? And again, you can use the same sample types we talked about before, tongue fluids, processing fluids, oral fluids, or tissues that you submitted to the lab. Also possible to do that with serum or blood, and that's going to allow you to understand if there is active viremia in those animals that you sampled. So lots of different samples that you don't need to actually euthanize an animal or necropsy an animal to understand in the population what's going on with a little bit of about PCV2, right? You also can use serum to test for antibodies. There are different antibody assays that are available for testing. Very common ELISAs that are available in different countries to detect that antibodies and assess the dynamics that you're observing in the populations across time. Very useful for understanding that dynamic over time in different herds. Can use it in serum or oral fluids. For oral fluids, the value is a little bit limited just because it's a population sample, and when you're trying to understand the antibody dynamic, it's good to get to that individual level to try to understand the variation within the population and where things are going, what are the trends in different animals. But if you're trying to have confirmation of diseases caused by circovirus type 2, what you need is the combination of those different tools, right? You can use PCR, histopathology, and the immunohistochemistry, which is very, very similar to what we talked about for PCV3 just a little bit ago. So you gotta be able to detect the virus, observe the lesions that are consistent with PCV2, and then confirm the virus within those lesions. So a little thing, what to do and not do when you're talking about diagnostics and diagnosis for PCV2. So let's start with don't do. Don't rely on PCR alone, because just as PCV3, PCV2 is also everywhere, right? So you want to make sure that you're using more than one tool to try to understand what PCV2 is doing. So relying on PCR alone is very, very tricky. Don't diagnose from blood only. Again, you may need tissue confirmation just because, for example, even in vaccinated animals, you will not expect that all of them would be negative. You know, the animal can be vaccinated, have virus, and not have anything in the blood. Don't assume vaccinated is clear, so virus can persist in subclinically in the population. And also, don't forget about different cofactors. PRRS virus, stress, and other pathogens can influence how PCV2 is going to present in individual animals, but also in the population. Now, what should we do? We need to look for lesions that would be consistent with those different diseases that PCV2 can cause. So we want to find the virus, and we also want to see that the damage that's caused to the different tissues that would be associated with the different clinical presentations of PCV2. Key samples to send to the lab are lymph node, tonsils, and spleens. You can also send other samples that would be associated with the clinical signs that you're seeing in the field. So if you have respiratory disease, make sure that you include your lung. If you have enteric disease, make sure you include intestines and colon. Fresh and fixed, so we can do all the different tests that would be necessary. Combine all the tools, right? This is very important for PCV2, PCV3, and basically every other disease. You want, again, to stack up the evidence to be as sure as you can that pathogen is important and is the cause of the clinical signs that you're seeing in the field. And interpret everything in context. So the PCR especially, because PCV2 is so widespread and you are expecting it to find it in the population, that by itself, it's not going to tell much, right? So you gotta use other tools that are available to you to make sure that PCV2 is really important. So if you are suspecting the different presentations, so you have here systemic disease, reproductive disease, and the PDNS format. Here are the things that you should be ordering to the laboratory, and some of the tissues that should be looking for this as well to send to the lab, right? So if you have systemic disease, lymph node, lymphoid tissues, fresh and fixed are very important, and then lung, heart, liver, and kidney. If there are other clinical signs associated, you'd be sending that. For reproductive disease, usually we recommend that people send to the lab the whole fetus, because then we can collect those samples aseptically from the fetus in the lab. But if that's not an option for you, what you'd send to the lab is heart, lung, liver, kidney, and placenta. You can also send stomach content that's usually used for culturing to make sure that we don't have any bacterial pathogen that would be associated with those clinical signs. In fetal thoracic fluid, it's a very clean sample in case we have to do other molecular tests to detect different pathogens. For PDNS, basically skin, kidney, lung, and lymphoid tissue as well. That was not part of my presentation, just to be but again, what to test for, always go for the PCR, histopath, and then the confirmation through either in situ hybridization or immunohistochemistry, depending on what's available in your lab. And what you want to find is consistent lesions with the different presentations. PCR detection at a low CT, and the confirmation with the in situ hybridization and or the immunohistochemistry. So again, just to reinforce, before doing any tests, especially if you're talking about surveillance, it's important to try to understand what the question you have is and what you're going to use that information for before you collect those samples. You have different diagnostic modalities that you can go for. And so some of the uses that we can do if you're doing surveillance, again, if you're doing PCR-based, you can do detection and quantification of virus in different populations. You can look for cell farm stability, which is a new concept that we can talk a little bit about later in the next presentation. We can look for PCV2 reproductive disease in different sample types associated with those abortions, mummified piglets, and then you can do surveillance as well for using tongue tips, processing fluids, serum, and oral fluids. Again, guidelines for interpretation of those do not exist, but if you are tracking that pathogen over time, you can observe those trends and try to decide if you need to do a confirmation of PCV2 disease through a more extensive diagnostic process. And for antibody-based, you can evaluate antibody dynamics over time in different populations and also response to vaccination. And again, the thing that's important to have in mind is that you gotta always consider that those tests may have variability between different labs and different techniques. So talk to your lab to understand those constraints and also take in consideration the individual peak variability when you're interpreting those test results and always correlate it with the production performance. So take homes here, know the reason for testing before you do test. Diagnostic investigations, they need to follow a specific process to try to understand if PCV2 is truly involved. And then monitoring and surveillance interpretation is difficult, and you gotta always correlate that with your production performance because the pigs in the end are not gonna lie. So do not create a problem where there isn't one. You know, always try to associate as much information as you can before you blame something on PCV2. Back to you, Oliver.